Hello and welcome. Welcome back, or welcome for the first time, to the MBLEx review course. My name is Jodi Scholes. I'm your instructor. We come together live every week to study for the massage and bodywork licensing exam. This is a really fun live class. At the end, we're very interactive. At the end of class, about the last 15 minutes of class, you're going to have a chance to dissect some questions and give me the proper answers. But that's just one section of class today. Today's class is client assessment, reassessment, and treatment planning. Yes, all the yummy details of how to plan a treatment session. And we're going to get clear on some vocabulary as well. We have a lot of vocabulary, actually, and you'll see that in our lesson. Today's session is in 3 parts. I'm going to give you in the beginning here some test taking strategy. Then we're going to go into our learning, and then we're going to be dissecting questions. And you guys have requested more questions. That's great. So I think we have 10, at least 10 questions to dissect together on client assessment. And so the test-taking strategy, part 1 of our class that I want to share with you today, is about your game day. About your game day. What time of day are you taking your practice exam? Excuse me, your MBLEx. Do you already have a day and time? A test-taking strategy is to take our MBLEx simulation exam at the same time of day. So coming up, I know we've got one person testing in the next 7 days. That person happens to be testing at 5 p.m. So a good habit is to go ahead and sit down at the computer, not on your phone. If you're listening today from your phone, hey, welcome. Glad you're here. But when it comes to taking the simulation exam, you are sabotaging yourself by doing it on your phone. You say, why? Why would that be? You're not taking the MBLEx on your phone. You're taking the MBLEx on a computer. We need to simulate as much as possible your circumstances, your surroundings on game day. I call game day your MBLEx day. So just like pro athletes have game day, like NFL, football or American soccer, or baseball or hockey, they all got game day. And how do you prep for game day? One of the things is, what time of day are you scheduled for? Once you know that, start taking those MBLEx simulation exams at the same time. One other way you can prep for your game day. I want to also mention that Tara made a post this week that said, did you know that you can save a copy of your practice exam? Yes, you can. Now, no system is perfect, and that includes ours. However, at the very end of your simulation exam, at the very end of your immediate feedback exam, remember we have 2, right? We have 2. I'm going to let you be able to see me a little better here. We have 2, right? We have the immediate feedback, which is a great learning tool. And then we have the simulation exam. So you can save a copy of your exam to your own computer. How do you do that? Well, in case you missed the post, I want to walk you through. When you submit that last question, a screen pops up and it says, review your exam. or continue. There's two buttons. And the continue button is highlighted and bright. So you might be like, okay, continue. Ooh, wait. If you want to review your exam, click review your exam. Now, in working with this system, in teaching you, in preparing these lessons and getting all of the information into our online learning platform on Digital Chalk and all of these things, I've had to become more tech savvy. Guess what? You get to become more tech savvy too. And at the end of your test, you're going to watch for those two buttons. You get a score, and then there's two buttons, review your exam or continue. Go ahead and click on review your exam. You are going to be delighted because the exam opens with the answer key open. So you can see the best answer. Now, you may be wondering, okay, how do I save it? All right, this is where you got to put on a little technology hat. You save it by, bear with me, printing it. So there's a little button that shows the button, a little picture of a printer. Click printer, but don't print it. It's 50 pages if you print it. Hopefully you're at a school printer if you print it, or a library. Well, hopefully not, because you'd have to pay for it. But just click the printer, and then where normally you'd hit OK to print it, don't hit OK. Go up to the box where it shows what printer you would be printing it to. Click the little arrow that's in that box of the name of your printer. So say it's called Jodi's printer, or Val's printer, or Tara's printer. Click in there like you're going to change the location of the printer. You're going to pick a new printer. And what you're going to find in there is save as a PDF. Whoa! Hidden away in the printer button, yes, is where you save it as a PDF. Wow, right? Yes. So because that sequence of events is sometimes challenging and sometimes you forget or sometimes don't think of it, we are also able to go in and save a copy of your exam. As long as we haven't cleared the results. Once we clear the results, bye-bye. That test is no longer there unless we've already saved it. So we're coming up with a sequence now that if you pass your practice exam, we're just going to save it in case you want to copy later. But you can save it right away by going through that sequence. When you finish your test, so here's a review of the sequence. When you finish your test, you get a score. And then there's two buttons, review my exam or continue. You're going to hit review my exam. And you can sit there and review your exam. That's great. But if you don't get all the way through or you want to come back to it later, click the printer, click the window like you're going to change the printer. And what you're going to change it to is save as a PDF. Yes. When you save it as a PDF, the answer key is open. You can go back and review those questions that you had challenges with later on. Save it as, I usually save it as your name, but you can save it as practice test. Maybe with the date, practice test, maybe with the score. But name it something consistent. You guys are taking practice exams consistently. I'd like you to be able to find those practice exams again when you save them so that you can review them on one of those study days that you've dedicated to reviewing practice exam questions. All right, That's my test taking strategy for you. The strategy is take the simulation exam at the same time you're going to be taking your real MBLEx. If you don't know, then just plan it out accordingly that you have that nice 2-hour block. Once you have your date and time, move that, slide that, if you will, or try and pick a day and time that you've been practicing, right? But go ahead and line those 2 times up. The time that you're taking your MBLEx and the time that you're taking your practice exam, your simulation exam on a computer, line those 2 times up to, again, take it to the next level of simulating your MBLEx. All right. That's my practice. That's my test taking strategy for you today. Look, we're going to learn a lot today. But passing that MBLEx, it's more than just learning. You know, for all of those of you who have taken it before, man, there's some strategy that goes into this. Yeah. All right. But so now you have another tool in your toolbox for how you're preparing, the time and the PC, right? The computer. Now let's do some learning. I think we have one more in the waiting room. There we go. Ready for some client assessment? Mm-hmm. All right. What I learned over the last couple of weeks is that it's really better to just hide everybody so that you can see our slides. All right. Now and then I'll poke my nose back in here to give you a big old smile. But this is client assessment. Client assessment, reassessment, and treatment planning. And according to the Federation of State Massage Therapy Boards, these are the topics that could be on your MBLEx. You will need to understand how to organize a massage and bodywork session. You will need to be comfortable with the terms, the vocabulary, the procedure of a client consultation and evaluation, and that includes the verbal intake and the health history form. You'll need to be comfortable with written data collection. That means writing notes. You're going to be comfortable also with the visual assessment. So general assessment, a postural assessment, a gait assessment. You're going to need to know what these things are. Yep. Also, you'll notice here, 17% of your MBLEx is client assessment, reassessment, and treatment planning. So we know out of 100 questions, 17 are going to be on client assessment, reassessment, or planning your session, or documenting your session. Additionally, the Federation says you'll want to understand palpation assessment, range of motion assessment, just know what it is, and be able to use your clinical reasoning. So after you gather all that data, after you're the detective, after you look at that health intake sheet, you watch them walk down the hallway or gait analysis or postural analysis, that you're going to be able to take all those ingredients and make a good soup. That's basically what clinical reasoning is. You're taking all of those ingredients, all of that data that you have collected, and you're turning it into a fantastic session, a fantastic massage. All right. Not only do we look at the Federation and what they say is on the test, but we go a little bit deeper here in this class, in this session. We take a look at ELAP. the entry-level assessment program, the core. This is a over 200-page document produced by amazingly dedicated, intelligent pioneers of the massage therapy profession. They came together for 3 years and decided on what the core curriculum of any massage school should be. This is a free public document. Yeah, free. I know, it's amazing. And so not only do we look at what the Federation says, but we also look at what the core curriculum covers as far as this particular blueprint of massage school. So what would you have learned at massage school? So an overall assessment techniques for massage and body work. You're going to, in school, you covered the health forms and how to do a good client interview. You covered your general observations and also that client's level of health. Are they coming to you healthy? Are they coming to you with a lower level of health? You learned how to palpate. You learned how to assess posture, range of motion. You learned how to ask about pain. And you learned about the range of motion, but functional limitations in the range of motion. You may not have realized you learned about functional limitations, but you did. We're going to cover some of these things today. I wanted to give you just a little scare. And this is the vocabulary list from the core curriculum. And when we post this video, you can come back and screenshot this. I'm going to give you some good news at the end of this list of vocabulary. We're not going over all of this vocabulary today because this is massage school. This list is from school. And oh, it continues, by the way. Yes, all of these terms are terms you're going to want to be familiar with. Good news. I asked Tara if she would make us a worksheet, and she's going to make us a worksheet, and I will post that with our session today, with the video of our session today. So you don't have to scratch all these out. We're going to create a worksheet. Tara's going to create a worksheet for you. Thank you, Tara. Tara's our operations manager. She communicates with you also via email from lmtvictory@massagegrads.com. And so you can watch for that. Messages from her come from that email, but this will be posted in our Patreon site. This worksheet will be posted with the video recording of this class. All right. So as you see, those are the components of what the core curriculum will have covered. But we're coming back to what the Federation says is on your test, and we're going to talk about the organization of your massage and bodywork session. And I'd like you to visualize your intake. How do we make a massage super successful even before it starts? And I love this sequence, although in our vocabulary, the treatment plan is actually the P of the SOAP notes. So in this case, it's not properly labeled, but you can visualize this is prior to your session, prior to you ever putting them on the table. This is how we create a successful session. Find out what prompted their visit, what made them choose massage, why they scheduled their appointment. We're going to talk about open-ended questions. We're going to be taking notes on what they said. Okay, left hip, You're going to do a thorough assessment based on the time you have available, and then finding out, really identifying, it sounds like the ultimate goal of your session today is that your left hip feels better. This is all before you put them on the table. You're familiar with a health intake sheet. This is what guides the client interview, the client conversation, the client dialogue. You're going to review the written data, especially if it's their first time getting a massage or first time with you getting a massage. Of course, first time getting a massage, but yes. So you're familiar with walking through, seeing anything on that health information sheet, areas on their body. I love that we've got areas that they can circle on their body. This is where I'd like attention, mark any area. This says appropriate stress zones. It could be where you want specific attention if they're not in any pain. But this is where we start to be the detective. We start to look for areas, their areas that they want attention. Once we've identified those areas where they want attention, we're going to ask some open-ended questions. Now, coming back to the MBLEx, there are 3 types of questions that you ask. So, of course, we're going to discuss and review that health intake form every time. They don't have to fill out a new health intake form every time, but we are going to have it available, or if it's not available for some reason, we are still going to do an intake every time. I mean, doesn't matter if it's the same stuff on a different day. We are still going to say, how's your body feeling today? Every time. Yeah. And for a new client, this can be 15 minutes or so to go through their health history, to accurately go through their health history. But what are those types of questions? And this is what you might be asked on the MBLEx, okay? We're going to look at general questions. We're going to look at specific questions, and we're going to look at pain questions. Because on the MBLEx, sometimes they try and fool you. MBLEx is a little tricky. Sorry, it is. The open-ended questions are sometimes also referred to as general questions. These are the questions that let the client tell their story. So, how did this happen? How did your ankle get swollen? When did how did you hurt your low back? Okay. They offer an opportunity for the client to think and reflect. There's going to be more words, right? We have different elements of clients. We have air clients, water clients, fire clients, and earth clients. You're not going to be asked about this on the MBLEx. But those air clients, woo, they like to talk. They love these general questions. Let me tell you my story, right? So some sample questions. How are you feeling today? What motivated you to come in for a session today? Can you tell me more about your daily routine? So these are considered open-ended questions. The next type of questions are specific questions. Specific questions are generally one-word answers. What area of your body are you feeling discomfort? These sometimes are yes or no questions. Is your back stiff? Are your feet tingling? Is your condition worse at night? Okay, that third line there says, on a scale of 1 to 10, how's your energy level? Energy, not pain. It's a specific question about their energy. If a question has the word pain in it, it is a pain question. We have 3 types of questions: general, specific, pain. Is pain worse in the morning? That's borderline because that's the word. It has the word pain in it, but it is about time of day. So we're getting an answer that's about time of day. So, have you had this pain before? That's a pain question. So, yes or no questions are typically specific, but if they have the word pain in them, it's a pain question. Pain questions: where does the pain hurt? How long has the pain been going on? What does the pain feel like? What triggers the pain? Is the pain constant? What do you do to cope with the pain? So be very careful when you're taking your MBLEx, whether it's a general, specific, or pain question. And the reason for these questions is they're client assessment questions, and they really want you to be able to have a well-rounded approach to understanding your client's condition. Okay, with that in mind, we have more vocabulary for you. All right, there are two different types of pain you might be asked about on the MBLEx. Yes, neuropathic pain and nociceptive pain. Now, good news is, if you're seeing these words on your MBLEx, that means you're doing well. Yeah, actually means you're doing well. Bonus, because these are hard questions. Okay. What are these? Neuropathic pain. Neuropathic pain has to do with the neuro, the brain, the nerves, right? A neurologist is a brain doctor, but he's really looking at pain coming from the central nervous system. So the nervous system, the brain and the spinal column are the central nervous system. Yeah. All right. So neuropathic pain is caused by the nervous system. So an injury or some impairment to the nervous system. Now, for both kinds of pain, it can be injury, trauma, disease, blah, 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 all these things, right? But all of these things are affecting the nervous system. That makes it neuropathic pain. So examples of neuropathic pain can be like when a client has diabetes, they might have pain in their feet, but their feet are numb. So we have peripheral neuropathy. If there's pain, tingling, shooting, stabbing pain with that peripheral neuropathy, that makes it neuropathic. It's pain coming from the nervous system. Shingles. Shingles is a disease that creates pain by inflaming the nervous system. Other types of neuropathic pain. We'll get to those by comparison in the next example. Nociceptive pain. Nociceptive pain is a fancy way to say pain coming from your body, your physical structures. Take a look. There's two types of nociceptive pain, visceral and somatic. Now, this comes from an injury, disease. Both these types of pain can come from an injury, inflammation, disease. But the difference is one affects your body, your organs, or your skin, or your muscles, or your joints. The other affects your nervous system. Nociceptive pain has two different types, visceral, and that affects your visceral organs. You will want to know that word, visceral. Visceral pain affects the visceral organs. So any of the soft organs of the body, the lungs, the heart, the stomach, the kidneys, the appendix, the bladder, any of those. Okay, so organs of the body. And there's a difference here. I want you to see there's a difference between pain from the organs and pain from the muscles and joints and skin. Many of your clients will come in and be, in fact, I just had this week. I have a personal trainer client, lovely lady. She comes in, she's like, there is pain in my hip. Do I have cancer in my hip? Your clients are not distinguishing pain from an organ from pain from a muscle. Yeah. So we gently guide them back to the musculoskeletal system. Look, if this is pain from an organ, they got a bigger problem. They need to see a doctor. Yeah. If their appendix is hurting, what quadrant of the abdomen is the appendix in? Might be asked that. Lower right. Double check me on that. But an organ, the appendix is an organ that a lot of times needs to be treated by a doctor. Whereas somatic pain, muscle, joints, bone, that's a little bit different. So moving along, visceral pain is from a visceral organ. Somatic pain is from the skin, muscles, joints, bones, still painful. We're dealing with musculoskeletal pain. That's under the category of somatic pain. So there can be injury, there can be disease. So, or there could be surgery, right? So the examples I use here is stubbing your toe, having a sprain or strain, a sports injury, a surgical procedure like dental surgery. You feel it in your skin, your muscles, the bones, the connective tissue. Nociceptive pain usually is sharp aching or throbbing versus neuropathic pain, although it can be described the same way. So you feel a throbbing sensation, somatic pain, you feel a throbbing sensation on your skin after you get cut. Somatic pain also would be like aching muscles after a workout. You're feeling it in your muscles. So skin, muscles, bones, connective tissue, that's all somatic pain. Visceral has to do with an organ. Okay. So I've already talked about the 3 types of assessment questions: general, specific, and pain. Pain can be broken down into 2 categories: neuropathic or nociceptive. Neuropathic, nociceptive, somatic, or visceral. Let's move along to the next bullet point in what the Federation tells us is part of what we need to know. And that is visual assessment. Visual assessment. This is going to include a general assessment, what you see as far as their symmetry. That's a word, a vocab word, their symmetry or their asymmetry. That's going to be general assessment, visual assessment. We're going to look at postural assessment and gait assessment. Let's have some fun with this. Yes, it's fun. So visual assessment includes movement analysis, walking, sitting, standing. So visual, your eyes, right? And if you are visually impaired, then there's other tools that you have other than just your visual, but you will need to know the category of visual assessment. You also have postural assessment. You have palpation assessment. And then there are some special tests that you can do as far as signs or symptoms. You might be trained in taking blood pressure or taking the vital signs. You might be trained in research literacy. Vital signs are a great way to document the benefits of massage if you're doing some type of research literacy or building a body of evidence, some qualitative research on the benefits of massage. However, that might be a little bit further down the road for you. So the visual assessment is a method of gathering data by looking at them, by observing their posture, their movement, their symmetry, their asymmetry, their skin condition, their body language. This is a classic postural assessment tool. And it demonstrates, again, being familiar with the procedure. If you're listening to this later on or today, and you are visually impaired, we have a number of visually impaired massage therapists. Yay! That they are becoming massage therapists. Be familiar with the procedure. Be familiar with the terms. So this is a postural assessment door chart, a wall chart, and it's a grid, and it allows us to see asymmetry. Asymmetry is the opposite of symmetry. Asymmetry is when it is not even on both sides. And this particular example is pretty symmetrical. We have a little bit of a difference here under the arm. This arm seems to be a little closer, maybe a little left forward, left shoulder forward. It looks like maybe the upper hand of her and her left side is twisted just a little. See how this left hand is forward? We could make some guesses that she's a left-handed golfer, left-handed tennis player, left-handed pickleball player. Maybe she's just left-handed. Yeah, who knows? All right, but this is the visual assessment with a wall chart. All assessment on your MBLEx, please remember your assessment is standing in anatomical position unless you are told otherwise. For the purposes of the MBLEx, your client is standing in anatomical position. They're not on the table. They're not supine. They're not prone. They're standing in anatomical position, unless you are told otherwise. Let's have some fun. What do you see? What do you see in this picture? Yup. If you walk into the waiting room and you see this client, she's your next client. What can you visually observe about this client in this moment? Let's compare it. Say your client was sitting in a different posture. Yep. This could be a before and after picture, right? You see that forward head position. We're going to take a look at what might be tight. What maybe in your mind's eye, if this was someone you were envisioning, you were seeing as a client, you were treating as a client, what's going to be tight and what's going to be weak? What's going to be tight? Let's start with what's going to be tight. But these are two great questions. What's going to be tight on this client? What's being pulled forward? Her shoulders are rolled forward, right? See how those shoulders are rolled forward? Ooh, we have some answers coming in. Ah, yes, Edgar, I like your answer. Yes. So the pec muscles, right? Ms. V says the obliques. Yes. Could be the neck. Yes, Patitya. Rolling forward, that rolled forward. So the shoulders are rolled forward, right? What attaches to the shoulders? The shoulders, classically the pec muscles. There's a second question there. This is client assessment, you guys. This is classic client assessment. I love it. So, what muscles are tight? But what muscles are weak? Let's see. We've got a little bit of kyphosis. Yes. Kyphosis is happening here in that thoracic region. That thoracic region is being affected by these rolled shoulders, aren't they? Could end up with a kyphotic curve. But what it also tells us is that in that thoracic region, let's see, scapula, great. Scapulas are rolling forward. Scapulas aren't muscles. What muscles are back there? What muscles help those scapulas to come back? We want those scapulas in the after picture, in the nice posture picture. Those scapulas have been retracted, right? What muscles are retracting the scapulas? Yes, those muscles, the ones that retract the scapulas, potentially could be weak. Let's take a look. Yep. Traps, yes. Rhomboids, yes. Rhomboids, best answer. Traps, a good answer. Both of them are involved. Correct. Because those are what retract the scapulas. So before you even start, before you even put your hands on people, you're looking at tight pecs and maybe weak, weak rhomboids. You're going to get in there and find out. Now, after your session, depending on what you discover, you might be in a position to demonstrate a wall push-up to help retract the scapulas. Awesome, easy, beautiful, simple exercise. Oh, such a great, try it sometime. Try it today. Try a wall push-up. They're not easy. Simple does not mean easy. Ha ha ha. So depending on how far you have your feet back is how difficult that's going to be. Beautiful way to start your push-ups though. With wall push-ups, you can show your client, because what is beautiful about a wall push-up is as they're lowering, it opens their chest. So it naturally stretches their chest. And also as they push up and lower, they're activating reciprocal muscle groups, the rhomboids versus the pecs, re-educating the nervous system on turning on and turning off. Because sometimes these tight muscles just get stuck on. They're just tight all the time. Trapezius, classic for that, right? Tight all the time. Here's another example. Shoulder retraction, right? So using that band, retracting those shoulder blades. It opens up the chest. Lovely opening of the chest. These pec muscles have to shut off so that these rhomboid muscles can turn on. Yes. So that's after your session, but it's another way for you to understand reciprocal muscle groups. Yes. Let's do another example. What do you see? What do you see? You see forward head position, right? What muscles in this first picture here, the picture on the left-hand side for you, this is the one with the forward head position. What muscles are bearing the weight? What muscles? Put your own head forward. What muscles do you feel kicking in there? You can actually see them working. Mm-hmm. Mm-hmm. Yes. Traps, baby. That's right, Jodko. Tinker. Traps, baby. Amy, you got it. Yep. See, look at her traps. They're carrying the weight of the head. 8 to 12 pounds is the actual weight of a normal human head, like a bowling ball. 8 to 12 pounds. What causes this, do you think? Hmm? We'll see in just a moment. We got a couple other answers here in the chat. Hmm? Like you to be more specific, Terrence? Yeah. So take a look at a lovely remedy for forward head position. This is something, again, after your session. So we've got treatment planning. We've got reassessment during the treatment. And we've got treatment planning going forward. Okay, let's show this client what it feels like to have their head in alignment with their spine. For you right now, I'd like you to imagine a string on the top of your head, both feet on the floor, sitting on your sit bones. If you can, hands on your knees, palms down. And imagine a string coming from your seventh chakra, the soft spot on your cranium, the very tippity top of your head. A string is pulling you up. Yeah, that is spinal alignment. And often, especially if you drive, let's see here, there's a tendency for the head to go forward. So we want to stack, yes, and Ms. V talks about the vertebrae. We want to stack those vertebrae and let the cranium sit right on top of it. Take a peek. This is a lot of the reason that people have that forward head position. The traps are working. The anterior neck is trying to kick in and support. But this is why we, as body workers, as massage therapists, we need to look at our own alignment as we work our way around the table and in life, right? Often this is the case. Using that phone, keeping it at eye level if possible. Computers at eye level, possible. So demonstrating the chin tuck is well within your scope of practice. So we've talked in the past about what is your scope of practice as far as what are you allowed to do. Go ahead and put your finger on your chin and push it back. Yes. And just a little awareness. It's fun to do this while you're driving. If you're sitting at a light, go ahead and do this. Whoops. Cranium wasn't over the spine there, was it? When you're on the computer, da-da-da-da-da. Ooh. Okay, da-da-da-da-da. Lovely, lovely awareness for that head positioning. Forward head position, a different way to describe that. Chin. I guess we could retract the jaw. Yeah, causing the neck to move, the head to move backwards. So these subtleties, you're going to need to be careful on your MBLEx. Yeah, look for that best answer. Another visual assessment with a chart, with the wall chart. Added the green line there to show you what you're seeing. You're seeing a bit of a flat foot on the left side. Now, this is very detailed, right? Usually only physical therapists are going to be doing this, or chiropractors do this. But for the purposes of understanding visual assessment, I wanted you to see this. Because flat feet lead to knock knees, a condition called knock knees, or medial rotation at the knee. Yeah. So a condition called a knock knee, we've looked at this in the past, versus a bowed leg. Knock knees come together, bowed legs bow out. All right. Let's take a brief look at gait analysis. Want you just to be familiar with it. Gait analysis, you won't necessarily be documenting the way these people are, but gait means walk. And so in some shoe stores, a shout out to PR Walk and Run in the Northern Virginia, Maryland, DC area, they do gait analysis before selling a pair of shoes because they want to know, how are you walking? Do you need help with pronation, supination? But we're not going to get to that level of assessment, but I want you to know about gait assessment. So this person is actually videotaping the walk. What's really fun for us is if we look at their shoes. The shoes they came, they walked in on. Can we take a look at the bottom of your shoes? Look at the bottom of your shoes. What do you see? Mm-hmm. Look at this picture here. What's happening with that left foot? Damn. Look at that wear pattern. Some balance is definitely off there. But it's really interesting to be a detective during this client assessment. Clients may not even know this is going on. And here we are helping them to understand more about how their body works and why they have the pain patterns that they have. Pretty cool, in my opinion. Oh, and just one more thing. You won't be asked about this on the MBLEx. This is a neutral foot, and this is an overpronator. But just work with it. If you get a crazy question about overpronation or oversupination, just go back to your shoes, go back to the hands, using your hands as if they were shoes. Can you see how they're rolling in on the left? Yes. So pronation, supination, just review that at another time. This today is about gait analysis, and we're just realizing, okay, let's just say for the purposes of doing the body work, where's there going to be pressure? It's going to be here, right? On that inside ankle. It's getting all jammy on the lateral side, and it's getting all overextended on the medial side. Yeah, check both sides of the ankle, basically. All right. Let's move through some stages of soft tissue healing. I want you to be familiar with the terms because we've talked in the past about acute and chronic as far as pain. However, acute and chronic, well, let's just take a look at this. Today, we're not talking about pain in this section of class. We're talking about stages of healing. Okay? We've got stages of healing. On your MBLEx, you may see the answers acute, subacute, chronic, and you're like, oh, that's pain. Take a peek. We're talking about stages of healing and the inflammatory condition. This is an inflammatory response. This is a friend of mine's foot. She twisted her ankle and it had an inflammatory response. Yeah. So the inflammatory response is caused, in this case, from an injury, but it could be from bacteria. It could be from heat. But this is actually caused from trauma, a rolling over of the ankle. And this is a classic sprain, strain of the ankle. Let's stay with the stages of healing. These damaged cells, so these hyperextended tendons and ligaments on the lateral aspect of the foot, the lateral aspect of the ankle, were damaged. They were overstretched. And those damaged cells released a chemical, mostly histamine, but sometimes those other ones too. I'm not as familiar with those other two. But it causes inflammation. You may think of histamine when you think of allergies, right? If we get an influx of pollen during our spring season, sometimes we can feel like we can have puffy eyes. We can just feel puffy. We can produce a lot of mucus. Mucus is the result of your body getting rid of the pollen, getting rid of the dust, getting rid of all sorts of stuff, whatever it is that is, around the pollen, it could be like leaf particles, but mucus is one way your body gets rid of it. Sneezing is another way your body gets rid of it. But in this case, we're looking at stages of healing. We're going to talk about an ankle. All right. And so once those chemicals are released, they leak into the tissue, causing the swelling. Now, the inflammation, recent studies have shown that the inflammation plays a really important role in the actual tissue repair because your brain needs a signal. Your client's nervous system is the messenger back to the brain. Hey, we need to heal the ankle. So, recent research shows that inflammatory condition is a signal. It increases the amount of repair work of the healing response to the injury. So swelling is actually necessary. And you get to unlearn something. To truly be a student, sometimes we need to unlearn what we have learned. To truly be knowledgeable, we have to be willing to unlearn what we have learned. And so rice used to be the go-to thing. Rest, ice, compression, elevation. Even the guy that invented it said, oops, I was wrong. Okay, so no more ice, guys. Ice and heat, you can alternate, but by using ice to eliminate the swelling, to decrease the swelling, we interrupt the DNA communication with the nervous system. It goes numb. Let's make it numb. Let's ice it. Let's get rid of that swelling. Let's make it numb. We interrupt the body's signaling for injury and tissue repair. Here's the new formula. So it used to be rice, and then it was price, which was protect, rice, ice, compression, elevation. Price and rice will be familiar to you. Meat may not be. I hope you don't see this on the MBLEx, but in case you do, movement, exercise, analgesics, and treatment. So what they're saying now is as long as it's not broken, gentle movement is going to be beneficial for that joint. Gentle movement. Eventually a little bit of exercise. This is for injury, for soft tissue injury. You're going to want to use analgesics like Advil, Aleve, Tylenol, aspirin, and then determine the best treatment. So, little sidebar here. Wanted to just offer you information about turmeric, valerian root, and magnesium. This is well within the scope of your practice to just have a research-based piece of information, such as the 2008, almost 15 years ago, a study out of Bleakley showed that this particular salve, let me let you see it, the comfrey salve, that this root ointment, it's an herbal supplement to apply topically, gave beautiful relief. And this is a salve that has some of these ingredients in it: turmeric, valerian root, magnesium. Seeing some comments here. Let's see. Yeah. Physiotherapist, yes. Both treatments, yep, beautiful. Seeing a physio, yes. Seeing a PT after an injury, also very appropriate. All of these, though, these are to be used in addition to treatment. Turmeric, valerian root, magnesium. Turmeric's a natural anti-inflammatory, as studied in many different studies. And now, super easy to get them. Turmeric gummies. You can just pop a couple each day. In fact, pharmaceutical companies now are trying to synthetically reproduce the benefits of turmeric. Hello. Why do you need to synthetically reproduce it when you have turmeric? It grows wild. It grows beautifully. Anyhow, they want to mass produce it, so they want it synthetic. I recommend using the natural sources. And over-the-counter anti-inflammatory medicines like ibuprofen are proven to are actually proven to change the process, the healing process, and actually should be avoided in certain studies. Sorry if that sounds a little contradictory because of the anesthesics. The anesthesics. We're trying, so a natural analgesic is for pain, okay? Anti-inflammatories reduce the inflammation. And we'd like to use some natural anti-inflammatories versus synthetic. So also on your MBLEx, look for little indicators like that. Anti-inflammatory versus analgesic. They're meaning two different things. Anti-inflammatory, decreasing the inflammation. Analgesic, decreasing the pain. All right, so meet, just so you've been exposed to it, movement, exercise, analgesics, and appropriate treatment. We say all that to give you the stages of healing. The stages of healing are acute, subacute, and chronic. All right. Acute and chronic mean basically what you think they mean. Each of the stages has its own characterizations, its own style, its own vibe, its own character, characterized. It's all of each of these stages have inflammation, tissue repair, and remodeling. Soft tissue goes through 3 stages of healing. Acute, right after you've been injured. There's a lot of inflammation there. Typically, that's where we see the most inflammation. Subacute can be anywhere from 7 days to 6 weeks. You also see this post-surgery. There'll be some inflammation. That scar will be vulnerable until up to about 4 to 6 weeks. And then that scar, the tissue repair has happened. And that scar is going to be far less vulnerable. And then we get to the chronic phase of healing, the chronic phase of tissue repair. That's when all the remodeling is happening. That's when we're seeing scar tissue lay down. That's in that chronic phase. That's where you get the remodeling. It's usually 6 weeks after, 6 to 8 weeks after, depends on the person. Up to 2 years. Depends what kind of surgery. Depends what kind of injury. Yeah. So be familiar with the stages of healing. A question about the stages of healing using terms like acute, subacute, and chronic. Okay? We are not talking about pain now. We're talking about tissue repair. Welcome to client assessment. All right. So we've covered a lot of our topics. We're going to come back to one more tool in your toolbox as far as client assessment, and that's range of motion. You may be asked on the MBLEx about range of motion. It is one of the tools we have. It's one of the things our clients tell us that, hey, I can't do this. I have restricted range of motion. Range of motion refers to the movement potential of a joint. So, and we can say should here. How should that joint be moving? I don't like to use the word should. I ask that you don't should on yourselves, you don't should on others. But in this case, traditionally, how does that joint move? Traditionally, what is full extension? What is full flexion? So this measures ligaments, tendons, joints, so bones, muscles, and going through a range of motion would be pain-free in a healthy joint, in a healthy muscle, healthy ligaments. going through a range of motion would not have pain. If there's pain, then you get to be the detective. What is causing the pain? Is it soft tissue? Is it a joint? Is it a bone? Let's take a look. Let's take a look at our special tests. Okay. So when you have a question about the range of motion of the shoulder, we only care about what the humerus is doing. I'm going to give you a distinction here between the shoulder and the shoulder blade, okay? So the shoulder and the scapula. Sorry, they're two different things. The scapula moves when the shoulder moves. If you are asked a question about the shoulder joint, about the glenohumeral joint, we only care what the humerus is doing. We're going to take a look at another example in a moment. When we are asked about the shoulder joint, we want to know what the humerus is doing. Let's take a look at the far left. This is considered flexion or elevation. You're not going to see elevation on the MBLEx. You might say, oh, they elevated their hand. Yeah. Just be careful of the words that are described in your question. We're typically going to be doing with flexion and extension, but I wanted to give you a few visuals on the humerus. In this lower picture in the middle, we're seeing flexion of the humerus. In the middle top picture, we're seeing abduction. This is a fabulous one of external rotation and internal rotation. You may not have thought of the humerus doing internal rotation, but putting the dorsal aspect of your hand on the spine creates internal rotation of the humerus. Did you understand that description? Did you understand the description? So in the lower right-hand corner, look at internal rotation. The dorsal surface of the hand is touching the spine, producing internal rotation of the humerus. Woo! Uh-huh. Yeah. So go over it a couple more times if that's something that was difficult for you to follow. Go through it. Oh, let's see. Hang on, we got some. Good. Let's take a look then now at the shoulder blade. When we are asked a question on the MBLEx about the scapula, the only thing we're going to be answering is what the scapula is doing. Flexion and extension do not happen for the scapula. Protraction and retraction happen for the scapula. Upward rotation and downward rotation. Let's take a look, right? So let's take a look. We only care about what the scapula is doing here. We look at elevation and depression. We saw retraction earlier, but here we also see a picture of protraction, protracting those scapulas. When we throw a punch using the boxer's muscles, that's serratus anterior. When we throw a punch, We're protracting the scapula. We're not talking about the humerus here. Different movement of the scapula. And internal and external rotation is of the humerus. We're not going to worry about that as far as the scapula. But with adduction and abduction, are they asking you, is the MBLEx asking you about the humerus or the scapula? Because with abduction and adduction, the scapula upwardly rotates or downwardly rotates. Yeah. Be very careful about the descriptions. Protraction and retraction. Retraction can also mean medial movement towards the spine. Yeah. All right. So making that distinction with client assessment questions, what information are you being given about your client for you to assess? Is it about the shoulder joint or the scapula? Got me? Okay. You may see also assessment questions about the range of motion of the ankle. We're not talking about the knee, we're not talking about the hip. They're asking about the ankle. So what movements do the ankle make? Dorsiflexion, plantar flexion, inversion, eversion. Sometimes, on rare occasions, supination, pronation is words that they use to describe the feet. What's happening with the feet? They're an over-pronator, over-supinator. But the movement of the foot, plantar flexion, dorsiflexion, inversion, eversion. So, and for a physical therapist, there are range of motion tests, for the ankle. And also, you cannot do a proper squat unless you have good ankle flexibility. So, again, pieces of the puzzle, right? It hurts when I blank. It hurts when I squat. Where does it hurt? It hurts in my ankles. I can't do a proper squat. My ankles my heels come off the ground when I squat. All right, well, let's look at the posterior leg compartment. Going to be something happening in the posterior leg, most likely in the posterior lower leg, right? All of those ligaments that attach to the heel bone. You're the detective. You're the detective. One other point about range of motion testing, and that is typically range of motion testing is not done more than 3 times. The reason being is that first time you're going to get a true baseline of assessing your client's true range of motion, that the limitations, is there pain? Is this an injury? Is it disease? Is it, how is it dysfunctioning? Now, if your client, if you do it too many times range of motion testing, your results are going to start to deteriorate. Deteriorate means decrease in accuracy. So too many times range of motion testing is going to decrease the accuracy of this test, decrease the accuracy of the pain. Those first 3 times, the first time and the first 1, 2, 3 times are going to give you the most accurate result. Why is that, do you think? And you could be asked this about on your client assessment. Why do you think doing range of motion testing over and over and over and over and over again might decrease the accuracy of the test? Muscle fatigue. What is the overall level of health that your client has? Are they elderly? Are they a triathlete? Either way, the muscles that you're testing could fatigue. And so your accuracy will deteriorate. will become less. And if you're asked about special tests, I don't care if you don't know them. I'm going to show you the Thomas test because that's the most frequent. Um, and I want you to understand the difference between a negative and a positive result on this Thomas test. So, in example, the top example here. All right, so the Thomas test is the client is fully clothed. Most range of motion tests are done fully clothed. So your client is laying on the massage table with their knees draped over the edge. So they have scooted down all the way so that their knees are bent and at the bottom of the table. So both legs, the hamstrings are touching the table. Now, the test, the Thomas test. Think of it as an English muffin, Thomas's English muffins. The Thomas test. Go ahead, the client pulls one knee towards their chest. We are testing hip flexor tightness, psoas tightness. Bringing that knee towards the chest will produce one of two results. You see those two results here in the cartoon picture. When the knee comes towards the chest, the opposite leg will either stay on the table or come off the table. If the leg stays on the table, that is a negative result. Nothing happened. No movement. Negative result. No problems in the hip flexors. When the knee comes towards the chest, if the opposite leg raises up off the table, that is a positive result. Something happened. Positive, something moved. That indicates a tight hip flexor. You have a runner client. Might be fun to do this. It's going to help you to know whether or not you need to work the psoas. Now, that might be an advanced technique for you, but it's one you can learn over the first 3 to 6 months. Maybe you learned it in school. Maybe it's been a while since you practiced it. It'd be fun to work the psoas while you're practicing, while you're studying for your MBLEx to be prepared. Practice this little Thomas test. Now, I do want to give you the name of a piece of equipment. I don't think you're going to see it on your MBLEx, but just in case, this goniometer, I don't even know how to say it, goniometer, maybe. It's used by physical therapists. It's this thing that looks like the little, the jaw, like a little, like a duck, like a bird's beak sort of thing. It tests range of motion, and how much range of motion is possible. Now, looking at this particular photograph, there's someone on the massage table. The right leg is down, the left leg is up, and the right leg is flush to the table. Would this be a positive or negative result? Based on what you just heard, that leg with the right leg is flush to the table. It hasn't moved. Hamstrings are still attached to the table, touching, but the knee is towards the chest. This would be considered a negative result. Nothing happened. Negative result. Nothing happened. Yay. Good. No problem. Right. Good. Mm-hmm. Okay. So, in looking at special tests, they are testing range of motion. They are testing tendons, they are testing ligaments, testing joints. These tests can be done in gravity, standing up, or while laying on the massage table, taking your client, quote unquote, out of gravity. So that's a nuanced phrase, but more so what I want you to remember is there are three types of range of motion: passive, active, or active assisted. Now and then you see restricted, but let's focus on these three so that you can fully understand them. In each of these descriptions, we are talking about the client and the client activity. These describe the client. So passive range of motion means the client is passive. They are not helping us. The client is not using their muscles. So passive range of motion, when an outside force, such as the massage therapist or the physical therapist, moves the client. In our vocabulary today, we saw the term end feel. The end feel. And in range of motion, we are looking to take a client through a range of motion where we get to the end of where they can move. We, as the therapist, feel we can't go any further. So in the image you see here, we see a knee bent, and that knee is going to come up towards the chest. But at some point, it might stop prior to getting all the way to the chest. That would be, the end of that client's range of motion. In this case, the therapist is moving the leg, although this client does have the hand on the leg, but the therapist is asking, just please let me move your leg. Client is fully clothed. They're on the massage table. Okay, this is passive. The client is passive. Guess what active means? Active means that the client is actively moving themselves. You are not assisting them in any way. The client is active. So we ask the client to abduct their arm, raise their arm overhead. We ask them to reach across their body or laterally adduction in the normal plane, abduction. The person simply active range of motion is that person moving their own body part. So guess what assisted is? Yes, assisted is when we help. Oh, your client says, oh, I can raise my arm, but I can only get it to halfway. I can raise my arm, but I can only get it to here. I may be able to assist you. Likewise, if you see active or restricted range of motion, be careful. Read the question carefully as far as what is restricted. There are times where we do a test where we'll ask the client from anatomical position, I'm going to resist. I'm going to give you a little resistance. Hold your arm in place. Does that hurt? No, it's okay. Okay, go ahead and lift. I'm going to give you a little resistance as you lift. So just be careful. That is a descriptive word that is used for range of motion. It is used for special testing. So the three you'll want to know is passive, active, and active assisted. And just watch out if they throw in the word resist in there. Final component of the of our assessment tools is palpation. And palpation is when you touch. What are you looking for when you touch? You're looking for, is the tissue warm? And is the tissue receiving adequate blood flow? Is the tissue cold? By touching the tissue, they say, oh, it hurts right here. You're touching it. That builds rapport with your client. Rapport being a comfort level, it builds trust with your client. And by palpating, you're demonstrating a sincere interest in understanding the client's concern. Show me on me is another way. So, oh, it hurts right here. And sometimes my client will actually touch my back. Be like, right there, that's where it hurts on me. Those are using palpations in your client assessment toolbox, the tool of client of palpation. And finally, we are moving into one more component. One more thing they say you need to know, and that is contraindications. Yes, I'm going to wrap up this session today by talking about contraindications before we move into our dissecting of the questions. So, understanding the difference between local contraindications and general contraindications. Local contraindications are specific. They're a specific area. We avoid the local area. But a general contraindication is also sometimes called an absolute. We can't do the massage. It could cause more harm if we do the massage. It will be your job to determine, is this a local contraindication or is it a general contraindication? Let's review what both of them are. Local contraindications, avoid the area. Cuts, bruises, new joints, don't go there. Recent surgery, hives, stitches, burns, a rash, spasmodic torticollis, athlete's foot, any fungus, varicose veins, psoriasis, eczema, neuropathy can be a local contraindication, but that's a depends. So it's a specific area that's sometimes massage can help peripheral neuropathy, and that's normally the case. But it depends why. So that's like a little asterisk, a question mark on that one. Wanted to mention that psoriasis is not contagious. You can't catch it. Plaque psoriasis makes up about 90% of the cases, and it just doesn't feel good to massage it. So it's a local contraindication. Clients from psoriasis can benefit. You're going to need to have a conversation with the client. Does it itch? Is it uncomfortable? If it is, you probably don't want to rub it. But in the case here of the back, it could be beneficial. Just depends. So if you get a question like this on the MBLEx, be very careful. Typically, it's a local contraindication. Most psoriasis is plaque psoriasis and looks more like this on the arms, where it's just going to be irritated, dry, and they pretty much want you to avoid it. That leads us to a general contraindication for massage. This again means it's absolutely contraindicated. It could cause more harm to the client if we do the massage. Flu-like symptoms, high fever, fever at all, 24 to 48 hours, 24 to 72 hours after chemotherapy. Let's just say less than 72 hours is a general contraindication for chemo. Uncontrolled high blood pressure, nausea, vomiting, that is systemic, and it is a general contraindication. Concussion, doctor's note would be required. It would be considered a general contraindication. A high-risk pregnancy, any contagious disease, COVID, H1N1, those are all general contraindications because it could make your client worse or it could get you sick. Yay! Hooray! Time to dissect some questions. How you guys feeling? All right, these sessions are going a little longer. Just saying. We're covering more details. We're dissecting more questions. Here we are. You feeling like, all right, feeling good? All right, let's do this thing. Take a breath. No, little reminder. Some of you guys are new. This is your first time with us. The way we do this is we wait to hit enter. We wait to hit send on the answer. So even if you know it right away, we practice waiting. Quicker is not better. The exercise we are doing right now is learning how to be patient and truly know we picked the best answer. Too often, we read only half the question. There are clues in different parts of the question. Sometimes there's no clues at all, but often there are clues in every part of the question. Be careful. Be careful. You've been warned. So please wait until I say go to put your answer in the chat. That way everybody has a chance to answer. I mentioned previously that some people in our learning circle are visually impaired. Therefore, they are having a reader read them the question, or their computer is reading them the question. So, patience for yourself and patience for this process. It's good to learn patience. Let's do it. When do we do a client assessment? A, on the first visit, first client visit. B, on every client visit. C, when there has been a change in the client's health history. D, only on the first visit. After that, it's the client's responsibility to inform the therapist of any changes to their health history. We will be picking letter A, B, C, or D. We are looking for the best answer. We are going to eliminate one answer. When do we do a client assessment? Let's get rid of one answer. We are eliminating letter D. That is incorrect. That says we only do a client assessment on the first visit. After that, it's the client's responsibility to inform the therapist of any changes. Nope, that is not accurate. So when do we do a client assessment? A, on the first client visit. B, on every client visit. C, when there has been a change in that client's health history. 3, 2, 1, go. All sorts of answers coming in. Ooh, I like it. I like it. You know, there were 2 right answers here. Yeah, there were 2. There was 2 right answers, but there was a better answer. Okay. Lily, yes. Dora, yes. Ms. V got it. Good. iPhone number 2. Yep. Stephanie, you got it. Good. Good, good, good. Let's see. Raven, yep. Kershaw, got it. Lek, yep. Patitia, nailed it. Edgar, good. Amy, good. Brian and Diane, good. Stephanie B, yep. You all got it. Nobody was fooled. You were not fooled by the question. All right. Best answer on every client visit. Now, is A correct? Yes, it is. You do a client assessment on the first visit, but it's not the best answer on every visit. Okay, tough question coming up. Which of these conditions is an example of nociceptive pain? Which of these questions is an example of nociceptive pain. Oh, Lord. I just learned this. Nociceptive. So one of these, A, B, C, or D, is an example. The other, there's only one example in here. Okay. A. Which of these is nociceptive pain? Which condition is nociceptive pain? A. Peripheral neuropathy from diabetes. B. Phantom limb pain. C. Cutaneous pain. D. Post-herpetic neuralgia. Technically, that's the pain after shingles. Which of these conditions is an example of nociceptive pain? Now, you probably have no idea. That's okay. That's why we're doing this. However, we learned there are two types of pain. Today, we learned there are two types of pain. So let's get rid of one wrong answer. We learned there were two types of pain. In your mind's eye, look at your notes. Dude, don't say it out loud. What was the other kind of pain? Take a look. You wrote it down. I bet you did. All right, let's get rid of one wrong answer. Giving you a gift. Peripheral neuropathy from diabetes is not nociceptive pain. This is a tricky one. All right. Which of these conditions is an example of nociceptive pain? B, phantom limb pain. C, cutaneous pain. D, post-herpetic neuralgia. Pain after shingles, after the shingles virus. Make it your best guess. 3, 2, 1, go. Yeah. All right, let's see. We have to do this today. It's a little bit different. Ooh, okay. Got all sorts of different answers. Let's see. I'm looking. Looking. Jodco. Jodco got it. Let's see. Stephanie M. nailed it. Diane got it. Lily got it. Patithia got it. Brienne got it. Amy got it. Lek got it. Whoa. Kersha got it. Yeah. Best answer? Letter C. Cutaneous pain. Nociceptive pain is pain in the skin, muscles. This nociceptive pain has two categories, right? Somatic and visceral. Right? The visceral pain was of an organ, the soft visceral organs. The somatic pain was of the skin, the muscles, the joints, the bones. Yeah. So, nice job. So, phantom limb pain, peripheral neuropathy, and post-herpetic neuralgia. Good looky. Neuropathic pain. That's why I thought eliminating peripheral neuropathy as the wrong answer might be a gift, because you could see it wasn't the neuropathic pain, right? Did you write that down? Neuropathic versus nociceptive? Okay, just saying. If you got this question on the MBLEx, it would be a hard question. So bravo. Next question. When the client is able to perform the range of motion exercise on all extremities without assistance, this is called what? The client is able to perform range of motion exercises on all extremities without assistance. This is called what? A, active range of motion. B, passive range of motion. C, passive assisted range of motion. D, active assisted range of motion. When the client is able to perform the range of motion exercises on all extremities without assistance. Let's get rid of one wrong answer. Mm-hmm. Mm-hmm. Giving you a gift. Little gift. When the client is able to perform range of motion exercises on all extremities without assistance, it is called what? 3, 2, 1, go. Okay, let's see. Diane and Ms. V. Mm-hmm. Lily and Leisha. Yep. Dantasia and Stephanie. Yup. Raven, Patithia, and Edgar. You got it. Jodko. Yep. Kershik nailed it. Amy got it. Good. Brienne, Lek, Brenda. Yup. Nice work. You are not fooled. Best answer, active range of motion. Yes. So this describes the client, right? The client is active. Good. So client is able to perform without assistance. That's active range of motion. Next question. Which of these conditions is an example of neuropathic pain? Which of these conditions is an example of neuropathic pain? A, appendicitis. B, pain from a fractured humerus. C, trigeminal neuralgia, severe facial pain. B, being sore after a long workout. Which of these conditions is an example of neuropathic pain? Let's get rid of one wrong answer. We have eliminated letter A. Which of these conditions is an example of neuropathic pain? B, pain from a fractured humerus. C, trigeminal neuralgia, severe facial pain. D, being sore after a long workout. 3, 2, 1, go. Let's take a look. Ms. V, yes. Edgar, yes. Lily and Brenda, yes. Amy Patithia, yep. Raven got it. Good. Ooh. Stephanie, Stephanie M, Stephanie B, yep. Kersha, nailed it. Dora got it. Yeah, Ms. V, you got it. You got it. Jodko, got it. You got it. Best answer. C, trigeminal neuralgia. I give you a big hint in that one. Big hint. So neuropathic pain, So neuropathic pain is going to be to do with the nerves and the brain. And here, when we eliminated appendicitis, I gave you, it's a soft organ, right? Visceral organ, visceral pain. That's nociceptive. Remember, nociceptive is visceral or somatic. Visceral pain is an organ pain. Somatic is skin, muscle. So all of these are examples of either visceral or somatic pain, except for trigeminal neuralgia. And this is, they don't know what's causing this. Something's going wrong it's a severe facial pain. That's the name of it. Next question. What does SOAP stand for? SOAP. A, subject, object, assess, and plan. B, subjective, objective, assessment, and protocol. C, subjective, objective, analysis, procedure. D, subjective, objective, assessment, and plan for the future treatment. What does SOAP stand for? Let's get rid of one wrong answer. We have eliminated letter B. So what does SOAP stand for? A, subject, object, assess and plan. C, subjective, objective, analysis and procedure. D, subjective, objective, assessment, plan for future treatment. 3, 2, 1, go. Go, speed racer, go. Only one right answer here. Dora, Dantasia got it. Raven, yelp. Lek, yay. Patithia and Lisha, yes. Ms. V, good. Oh, Stephanie and Brienne, yup. Amy and Brenda, yes. Lily, Stephanie, yup, yup, yup. Ooh, Raven says, I've had this on my MBLEx before. I know, right? Best answer? Letter D. Subjective, objective, assessment, and plan for the future treatment. Look, letter A, technically right. Letter D, a better answer. Sorry. This is the point. We need to get to the best answer. I am instilling it into your brain. The best answer. Many of you answered correctly on the MBLEx. You answered with a right answer. You just didn't answer with the best answer. Okay. Next question. What is the form of question that tells a story? Client assessment. What is the form of question that tells a story? A, open-ended questions. B, specific questions. C, when we ask a client to rate 1 to 10 on the pain scale. D, closed-ended questions with a short answer. What is the form of question that tells a story? A, open-ended questions. B, specific questions. C, when we ask a client to rate 1 to 10 on the pain scale. D, closed-ended question with a short answers. Let's get rid of one wrong answer. Anytime we ask a client about pain, it's a pain question. It's a pain question. Okay. What form of the question? There's 2 right answers here. You got to pick the best one. What is the form of question that tells a story? A, open-ended questions. B, specific questions. D, closed-ended questions with short answers. 3, 2, 1, go. That should be interesting. Stephanie, Lily, and Fantasia, yes. Brienne, Jodko, and Patithia, yes. Raven, Kersha, and Stephanie B. Lek, yep, got it. Brenda, got it. Ms. V, got it. Lisha, got it. Lisha. Amy, yes. Nice. Best answer. Open-ended questions. Oh, you're saying that. Hey, a little tricky. Two right answers. Miss V says a little tricky. Yep. Pretty much every question on the MBLEx is tricky. Tricky. So why is this the best answer? It is the best answer because closed-ended questions with short answers are still closed-ended. The best answer is that open-ended. Tell me how this started. Closed-ended, it's like, okay, tell me the last week. They're still going to tell you a story, but it's more closed. Open-ended questions invite the client to just give you all sorts of details. And that's what we want. Ready for the next question? Ha ha ha. We have three types of questions: general, specific, and pain. Of these four questions, what's the pains question? Which is the pain question? A, on a scale of 1 to 10, what's your level of pain right now? B, your pain started about a week ago. How are you feeling overall today? C, have you received other treatment for this condition? D, what medications are you on? We have three types of questions that you will need to identify on your MBLEx. General, specific, and pain. Which is the pain question? Let's eliminate one wrong answer. Nothing to do with the medications you're on. Nope. We have three types of questions: general, specific, and pain. Which is the pain question? A, on a scale of 1 to 10, what's the level of pain? B, your pain started about a week ago. How are you feeling overall today? C, have you received other treatment for this condition? 3, 2, 1, go. Ms. V, Leisha, Amy, yup. Oops, sorry, I was a little too high. Amy, yes. Patitya, yes. Raven, yes. Fantasia, got it. Brianne, nailed it. Lily, yup. Stephanie M, yup. Ms. V, yup. Leisha, yup. Stephanie B, good. Edgar, good. Jodko, yup. Brenda, nailed it. Lek, nailed it. You weren't fooled. You weren't fooled by this question. Huh. Best answer. A. On a scale of 1 to 10, what's your level of pain right now? The question is specifically about their pain. That is why it is a pain question. Letter B says the word pain. Your pain started about a week ago. How are you feeling overall today? It's a general question. It's an open-ended question. How are you feeling overall today? Good. Nice work. And we continue. Internal rotation of the upper extremities can result in the dorsal surface of the hand facing which direction while walking in a relaxed, by walking or in a relaxed standing posture. All right, ready? Let's read it again. Gonna need to do this movement for you to probably get this. Internal rotation of the upper extremities can result in the dorsal surface of the hand facing in which direction while walking or in a relaxed standing position. Be careful on the question. So the answers are A, posterior, B, anterior, C, medial, D, lateral. Internal rotation of the upper extremities can result in the dorsal surface of the hand facing which direction while walking or in a relaxed standing posture. Let's eliminate one wrong answer, shall we? Mm-hmm. Can't be dorsal. If you're wondering why can't it be dorsal, we will talk about that momentarily. Internal rotation of the upper extremities can result in the dorsal surface of the hand facing which direction while walking or in a standing position. All right, 3, 2, 1, go. Tell me what you think. Mm-hmm. Let's see. I think I'm on to the right answers here. Let's see. So make sure I'm on the right answers. Let me go back up here. Ms. V, yes. I'm going to need to give credit for, I am going to need to give credit for 2 answers. Mm-hmm. All right, there's going to be a best answer. This is really close, and there are 2 right answers. Mm. Okay. Dora, yes. Ms. V, yes. Stephanie, yes. Amy, yes. Leisha, yes. Edgar, yes. Raven, yep. Jodko, Kersha, Lek, you'll get credit. Patithia, yes. Best answer. Lek, yes. Maria, my opinion, best answer. Yes. Best answer, anterior. So say you got this kind of question on the test. You got 2 right answers, B and D. Assume the worst case scenario. What is the worst case scenario? You guys had it, right? You understood the dorsal surface. We started from anterior. We started from anatomical position, right? In anatomical position, guys and gals, the dorsal surface of the hand is facing posterior. So with extreme internal rotation, oh, let's see. Yeah. So slight internal rotation would make the dorsal surface go lateral, but wicked internal rotation, big internal rotation, would make the thumb space in and the dorsal surface anterior. And technically, really, really bad would be medial. The most common condition, though, is when that dorsal surface is anterior. But what's good is that you realized all 3 of those. If that dorsal surface is not posterior, then now most people don't walk with their palms forward, okay? They would normally walk with their palms facing forward, or excuse me, their palms. Most people walk with their arms, with their thumbs facing forward. That dorsal surface is lateral. That's neutral. But if you see someone walking with their hands, with that thumb turned medial and the dorsal surface of their hand facing anterior, evidence of upper extremity or internal rotation. All right, good. Good. That was a tough one. Next question. Your client sprained their ankle 3 weeks ago. They are in the what stage of soft tissue healing? So your client sprained their ankle 3 weeks ago. They are in the what stage of soft tissue healing? A, chronic. B, subacute. C, acute. D, there's no more swelling, so the ankle has healed. Your client sprained their ankle 3 weeks ago. They are in the what stage of soft tissue healing? Let's get rid of one wrong answer. We know it's not acute because it was 3 weeks ago. What stage typically is 3 weeks? Your client sprained their ankle 3 weeks ago. They're in the what stage of healing? All right. A, chronic. B, subacute. D, there's no more swelling, so the ankle is healed. 3, 2, 1, go. I love it. We're getting a little long in the session, so I'm not going to call out everybody's name, but you did a great job on this one. Whoa, anybody get fooled? Anybody get fooled? Nobody got fooled. Ooh, 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 yay. Best answer. Subacute. Yay. Good job. And there's a good possibility prior to the session, you didn't even know there was a subacute stage of soft tissue healing. Good job. Good job. Reminder that also tissue goes through 3 stages of recovery: acute, 3 to 7 days, subacute, and then the chronic. Yeah. For acute injuries, what acronym do we use to guide treatment? A, RICE. B, PRICE. C, NSAIDs. D, MEAT. For acute injuries, what acronym do we use to guide treatment? Let's get rid of one wrong answer. We have learned no more rice. So B, for acute injuries, what acronym do we use? B, PRICE. C, NSAIDs. D, MEAT. 3, 2, 1, go. Let's see. Ah. Again, we're getting a little long in the session here, so I'm just going to peruse. Careful, careful. Careful, careful. We had a 99% success rate here. Best answer, meat. Where's the meat? We have the meat. Yes. So used to be price, used to be rice, but now it's meat. So we'll see how that goes on the MBLEx. Woo! And that, my friends, is a wrap. Oh my goodness. Did we cover some material today? That is some good stuff. So great work on kind of sifting through all the different aspects of client assessment. These are all areas you could be tested on for the MBLEx. Wrap up this session of the recording by reminding you my name is Jodi Scholes. I am your instructor for the MBLEx review course. Thanks so much for being here. Thanks for stretching your brain into truly visualizing what it means to do a health intake, what it means to do a client assessment, how we consistently, almost all the time, are reassessing, and of course, how do we plan out that treatment for future planning. Have a great afternoon, great evening, great week. We'll catch up again with you here next week.